Good afternoon, everyone. We're going to go ahead and get started. Welcome to the Professional Satisfaction and Practice Sustainability Fall Webinars. Before we begin, we wanted to quickly review some housekeeping items. This session will be recorded and will be available after the event. If you have questions, please place them in the Q&A. We will have time at the end of the webinar to answer many, if not all, of the questions. Without further ado, let's get started with today's webinar. Today's speaker is Dr. James Jerzak, who is the physician lead of team-based care at Bellin Health in Green Bay, Wisconsin. Today, Dr. Jerzak will be presenting on telemedicine and team-based care, how to engage support staff to implement team-based care in telemedicine. Welcome, Dr. Jerzak. It's a pleasure to have you.
Thanks, Brittany. It's really great to be here. I'm really excited to follow up the webinar given by Dr. Hopkins on the 6th. Had a chance to watch that, and he really laid the foundation really well for what we're going to be getting into today. And we're going to get into a little more of the specifics of how exactly to move into a team-based model for some of the new telehealth and telemedicine challenges that we're facing. So at the end of this, we're going to get a little bit of the impact of COVID-19, which I'm sure that's been a significant impact for all of us. We're going to talk somewhat about what effect that's had on team-based care. And then we're going to get into the real nitty-gritty details of how to engage our staff to leverage team-based care principles in the telemedicine world. So Bellin Health is a relatively small healthcare system based in Green Bay, Wisconsin. And Green Bay is famous and infamous at this point. You know, we're famous for the Green Bay Packers, of course, and unfortunately, we're infamous now for the impact of COVID. We're one of the hot spots for COVID in the country, and we'll get into that a little bit and the effect that's had on us here at Bellin. So as I mentioned, Bellin Health is a relatively small system up here in northeastern Wisconsin, and here's some of the details that you can read at your leisure if you would like. But let's get into it. So we started to look at our team-based care model back in 2014 as we were trying to find a way to deal with the causes of burnout. And these were some of the things that we identified. We're really stressing out our healthcare providers and our other healthcare workers. The EHR demands, the large amount of work at the in-basket, and also the challenge of providing care to increasingly complex patients. So we developed a team-based model that we'll talk about a little bit. So added to all the stress facing healthcare workers now, all of a sudden you have the coronavirus on top of that. So what were some of the effects on that? And I'm sure all of you, faced a lot of these same issues. We switched our focus almost exclusively to COVID-related issues. Our face-to-face visits fell off significantly, as Kevin Hopkins pointed out at Cleveland Clinic. And this led to financial impact that was quite significant for Bellin. We did almost an overnight transition to video visits, and that was difficult because we didn't really have the infrastructure set up for that. And that really, a lot of the team-based care principles really fell by the wayside a little bit as we were trying to survive the COVID situation. This wouldn't surprise anybody here, and I can tell you from looking at my fellow partners here in the practice, everybody is facing this right now. It's really difficult dealing with all the stresses of a normal medical practice and then add to it the pandemic. It's been very difficult. So all of this reinforces the need for an effective team to help take care of patients. Now, when we talk about team-based care, everyone has a little bit different definition for it. This at Bellin was our definition. We had 3 components to this. The office visit redesign, where we featured the uptrained staff helping us with EHR work, expanded role for RNs in the office, and then we redesigned in-basket work, emphasizing the team approach, and we developed a fairly elaborate system for helping the complicated patients and helping our teams focus on population health. So the impact of COVID on team-based care was pretty profound. We had some staffing reductions leading to disruptions in previous workflows. The shift to virtual visits was stressing people out quite significantly. Co-location is a key part of team-based care, and that has been called into question a little bit with the proximity of staff members. And we found that the lack of staff support during virtual visits was quite a problem. With the team-based care model we developed, we had significant support for physicians and advanced clinicians in the office visit with EHR support by the team, the uptrained staff. And that was reverting back during the virtual visit situation, down to the doctors in the room trying to do everything on their own. And we really lost focus on quality measure work and some of the other population health work we were doing. So something had to change. So we came to a couple of realizations. First of all, COVID is not going to go away anytime soon. And our system couldn't withstand the financial impact it was having for all that much longer. So that was a concern, but also looking at the medical care that was being missed, the non-COVID medical care. And this is sort of an example, one of the statistics that we've seen, but the loss of immunizations and missed immunizations for kids, the usual colonoscopies, mammograms, a lot of data out there about care that was being missed. And that just couldn't go on. So we made some assumptions. We had to provide the care to non-COVID patients. We couldn't focus only on COVID. We had to develop systems that were safe for our providers and for our patients. We realized that virtual visits were going to play a significant role going forward, but we also realized that we were risking some of the gains of team-based care. So we worked on developing workflows for staff support during these visits, and we're going to get into the details of that a little bit as well. I will say that we did have to have some education in the community to patients about the fact that it's safe to come into the offices after extensive safety precautions were made, and to emphasize to them the need to continue their care for non-COVID problems. So what do we do? So we develop the new workflows. We're going to go into the details of one of them in a little bit. We worked a lot with IT, developing video capabilities, as I'm sure you all have. And one of the key things that we realized was that a lot of the advanced rooming techniques that our staff was using was falling by the wayside in virtual visits. And we came to the realization that the enhanced rooming had to be identical. So we're going to get into the details of that too in a little bit, but that was sort of a key principle for us. In general, getting in-room support by our staff would help us during virtual visits, and we'll talk about the details of that as well. And of course, for us in our team-based model, we had a significant change in the role of RNs to do visits, advanced care planning visits, RN blood pressure checks, Medicare wellness visits. So they were seeing a lot of patient visits in the old world. That's continuing because that helps sustain the system financially, but throwing COVID work on top of that was quite a stress for our RNs. So we've talked a lot about team-based care, and as I mentioned before, everyone has their own definition of team-based care, but for us it was trying to get everybody to work at the top of the skill set, not only to help the burnout factors on the physicians and APCs, but to improve the staff satisfaction, empowering them to be part of a team that works together to care for our patients. But if you haven't done a lot of work in a team-based setting, it's not required. This could be your step in the door for developing a team-based model. So let's get into the nuts and bolts. So a reminder from Dr. Hopkins of 5 steps, and if you haven't seen his presentation, it's definitely worth doing. He gets into the details of this way into team-based care for telemedicine. And now we're going to talk about our specific workflow. So this is going to get into the real details of what we're doing here. So this is for a visit with staff support. We'll talk about later what happens if there's not enough staff to provide that support. But this is the ideal visit now for virtual visits. I want you to compare this to what your rooming staff is doing right now. There's a lot of stuff that they're doing here, and when they get trained and are efficient at it, it doesn't take all that long. Some of my experienced staff members can complete a lot of this in 10 minutes or so. A key thing here is closing a care gap, so that improves quality measures with the team-based care model as your staff gets involved. And they set the agenda and pull up the documentation templates. Our teams have worked together to develop templates that they work with, and they're familiar with which template is appropriate for which visit. And they set the agenda for the visit. They print the labs that are done prior to the visit. And then what we found really helpful in this was if they schedule the next appointment in the room while they're rooming a patient. That doesn't necessarily have to be done, but my staff knows our protocol so well that they're able to do that. That's made us much more efficient. So after they do all of that, there's an example of Kayla doing some of the prep for our nurse practitioner partner, which you'll see in a second. So then what happens? So after they're done with the virtual rooming of the patient with all those duties, they get the physician or the APC and give a warm handoff, usually in front of the patient, of the issues that are going on. And then the MA or the LPN stays in the room to sort of man the computer. So the provider then comes in the room, and one of the key advantages of the team-based care models is the provider is able to focus on the patient without the distraction of the electronic healthcare record work, able to give the full attention to the patient. And since we started our process a few years ago, patients have loved that they're able to get undivided attention from the provider, from the physician or the APC. So, we go over the situation, the history, and we developed a plan. Meanwhile, the MA or LPN is pending orders and putting in whatever we need to have done. And then when we're done with the visit, we communicate with them the work that needs to be done to reinforce the proper tests that we want ordered in the next appointment. And then we're able to leave the room. And here's a view of Brooke, one of our nurse practitioners here at Bellin, and Kayla, her LPN that's helping her. So Brooke is on the computer on her iPhone here, directly communicating with the patient. And meanwhile, Kayla is doing the work on the electronic health record. So when we're done, the MA or LPN stays in the room, enters the orders, they make sure the next appointment's been set up, the appropriate labs are ordered, and then reviews the changes with the patient and trying to utilize teach back as a strategy to sort of make sure they understand the changes. And then the after visit summary, actually I put prints here. We do that for face-to-face visits, but for virtual visits, they're able to access the after visit summary on their patient portal. Meanwhile, the physician or the APC, we go back to our workstation, edits and signs off on the orders and edits the documentation. And we really have a goal of trying to close a visit before the next patient. We actually track that statistic and try to make sure that everybody's charts are closed by 6 o'clock that same day. And there's Brooke in the room finishing up the documentation at her workstation. So these wins, we always talk about the 3 wins of team-based care: the win for the patient, the win for the care team, and the win for the system. And we have a lot of data for this with face-to-face visits. The hard data on some of these things for virtual visits is just being developed, but definitely the enhanced engagement of the patient with the team members, we've noticed being a big advantage. And of course, like I had said before, the attention of the clinician on the patient is really a big advantage as well. And having staff support for quality measures makes a big difference. And my quality measures improved dramatically when I got onto team-based care because of the enhanced staff support. Care team, yes, for the physicians and the APCs, having the support obviously is helpful because that's such a significant risk for burnout. But the staff members generally are much more satisfied with this role as well because they feel involved with the patient care, much more involved than they did previously. And the care is more efficient. When the MA or LPN is finishing the visit, the physician or the APC can move on to the next duty that they have to do. So then the win for the system comes in a few different areas. The staff tends to be more satisfied. There's higher engagement, less burnout. We've had some success with recruiting of providers with a team-based care system. Access tends to improve, panel size tends to improve, and quality measures tend to improve, which is helpful in a value-based environment. We frequently get asked about the financial sustainability of these models, and we have a new way of thinking about this. It depends a little bit where you're at in the corridor. We talk about the corridor from fee-for-service to full risk. And when you see from this slide, some of the things that were important for fee-for-service was an increase in visits and coding accuracy. The RN visits helped us a lot with sustainability as well. TCM is a little bit easier with this system. But as you move toward full risk, there's other things that are important. Working with the community resources, growing the aligned lives. Our panel sizes have improved quite significantly with that. And ultimately, the decreased cost of care is going to be a benefit under the value-based system. So whether you're in fee-for-service or value-based, it's really is sustainable model in either of those systems. So there's obviously a lot of detail behind this that we don't have time to get into, but I wanted to show this to you just to give you some idea that it is sustainable. So this is another big question we get at presentations and talking to other systems about team-based care models. What about staffing issues? Often if you have a full team-based care model with enhanced support, if there's in-room support for your providers, you do need more MAs or LPNs to provide that full support. Now, a lot of systems we're no exception, have sometimes issues finding enough MAs and LPNs. A lot of systems use only MAs, but we didn't have enough in the area to do that. So we use both MAs and LPNs in a fairly identical role. We call them care team coordinators. But there's sometimes difficulty recruiting them. And now with the financial stress related to COVID, it's not a real easy time to go and ask for more staff members. That might be a tough sell at this point. So what about it if you don't have enough staff to do this? We found it does work. So a couple of the keys for working with one MA or LPN in this model, you have to try to keep the virtual enhanced rooming unchanged because there's so many advantages of the team-based care with the enhanced rooming, as we had talked about, the care gap closure and things of that nature, setting up the documentation. So our staff will go in and they'll set up the documentation template and start the HPI, and then they'll come out and hand off the visit to us. This is where it's key if they schedule the next appointment, because that makes it much more efficient for us able to close a visit right after we're done with the patient. So after they hand off the visit to us, after all the expanded rooming duties, then they can get out of the chart. That allows us to work in the chart while we're in the room. And they can go and do whatever else of their numerous duties they have to do, be in basket or prepping for the next visit. And they do need to be available for EHR support if needed. But this is where the advantages of enhanced rooming really comes into play. If they've done the refill pending, the care gap closure, set up the documentation, schedule the future appointment and labs, it makes my job in a room much easier. And I'm almost always able to complete the visit and with the patient without having them come back in to do anything else. Very efficient for us. And in the meantime, they're doing all the other duties that they have to do. So sometimes the question of telephone visits is raised. And what about that? What we found for that is it's actually efficient if the MA or LPN initiates a contact with the patient and performs virtual rooming. Ideally, we like to have complete enhanced virtual rooming, like with the video visit, but that doesn't always happen. It depends on how the day is flowing and the time that's available for that. But whatever they can do when they're virtually rooming the patient is really helpful. And if they're able to be in a room for the telephone visit, once my portion of the visit is done, they can just take over and do the rest of the EHR work as listed on the screen there. And I can move on, and that just continues to increase the efficiency of the office. So now I notice my office is a little messier than I sort of wanted. Sorry about that, but this is just on a visit by myself versus having somebody in the room. Obviously, the PPE is important to wear. We use eye protection for any patient-facing contact. Masks are mandatory full-time, and we try to keep the 6 feet distance if at all possible as well. What about the RNs? Talked a little bit about the RNs in our project, their enhanced roles. They are really stressed out right now. They are having so many calls. Our clinic of About 14 providers had 850 calls one day last week related to COVID and to some of the ongoing regular non-COVID work that had to be done. So obviously that's pretty overwhelming. So we're trying to encourage the team approach to all this work. We're trying to encourage our providers to try to take some phone calls that they might have sent over to telehealth or to the RNs to do. So we're trying to really encourage a team culture to whoever has time, get into whatever work needs to be done and get it done to help other people out. And we did develop at our office a COVID team to handle all our COVID related work. And there's one of our RNs, Carolyn, who's been really excellent with all this. When I have questions about quarantines or any other issues related to COVID, she's our go-to person for that. So in summary, a few last thoughts about team-based care and telemedicine. Thinking about your staff, going through Kevin Hopkins' 5 steps for developing a model. One of the key things we found was when you're developing your model or your new workflows, be sure to include your staff in doing that. We actually, in the beginning, listed all the duties of every role, and then we, as a group with the different staff members, talked about who would be best to do those duties. So getting their involvement in this work really makes a big difference. It gets them to buy in a way that's really efficient and effective. Try to not let the EHR work revert back to the providers. It's something that is burnout inducing and really quite a bit less efficient. So having staff involved with that really makes a difference. And empowering your staff. We stress empowerment, encourage them to use critical thinking, look for things that they can do that would help take the burden off the other staff members. And as that leads to a higher level of patient engagement, they find a lot of satisfaction when they feel they're such a valued part of the team. And they get a lot of positive feedback from patients with this as well. And the patients really appreciate that. And don't forget the need to do the quality measure work and the other population health work to keep our patients and your patients healthy. There's a lot more to medicine right now than COVID, and we need to make sure that we deal with both COVID-related problems and all the other myriad problems that people have. And using a team approach really makes a big difference to make that happen. So thanks for your time. We have a lot of resources with the AMA. Kevin had mentioned the Steps Forward modules, which are expanding significantly, and there's a lot of details of a lot of the things we talked about today in the Steps Forward. And I'll hand this back to Brittany.
Thank you, Dr. Jerzak. After these next few slides, we'll transition to the Q&A. For additional resources to support your physicians and staff during this time, please visit the American Medical Association website. We thank you for your time today and hope that you're able to join our next scheduled webinar, which is scheduled next Thursday, November 5th at 11 a.m. Central Time, which will feature AMA's Stacy Lloyd, who will present on telehealth vendor evaluation, selection, and contracting. For general questions or comments, please email action.labs@ama-assn.org. After concluding this webinar, you'll have the opportunity to participate in a brief 4-question survey. We ask you to please take 2 minutes to complete this survey. Your feedback is very important to us as we continue to develop future programming. Now we'll take some time for questions. Again, please input your questions in the Q&A box. We're going to get our camera set up and then we'll jump in. Dr. Jerzak, I'll be reading the questions off to you. If any of our attendees would like to elaborate on a question or if you have a follow-up question, please go ahead and put it into the Q&A or chat box. Otherwise, we encourage you to use the raise your hand function and we will unmute you. With that said, let's go and get started with today's questions. Okay, Dr. Jerzak, the first question is actually an attendee asking for suggestions on how to keep support staff spirits positive with dealing with anxious patients.
Well, that's always a good question, and especially, in these times of COVID. Obviously staff is extremely stressed out. And, I guess one of the things, we do is just try to give facts, trying to reassure patients and give them the information. And again, I don't know if they referring exactly to COVID or just in general to the staff, but it's something we just have to pay attention to. And we really encourage communication with staff members. We have whiteboards that they can ask questions. We have weekly care team meetings, very important to talk about different issues. And just, when we talk about empowerment, just listening to them and giving them the okay to come up with their own ideas and ideas for improving our systems is sort of helpful for that.
Thank you, Dr. Jerzak. Looking to the future of telemedicine, what, in your opinion, are some potholes to be aware of moving forward with telemedicine, and comparatively some bright spots for the future of telemedicine?
Well, the efficiency of the visit without having to have the patient come in is obviously an advantage. Although it's interesting, we had a real dip in face-to-face visits, as I'm sure everybody did. And once we started opening up, it really rebounded surprisingly fast in terms of face-to-face visits. So the technical problems are an issue we're still dealing with. Just having, some of the ways to get these done require the patient portal, which can be a challenge. And for some of the older patients, and not just necessarily older, but some patients in general just have a trouble with the technology. So we're trying to explore different, ways to do the video visits, as I'm sure everybody is. So I don't know, there's some systems have set goals for video visits. Some systems are doing a huge number. I've been really happy with some of the types of visits, how efficient they are video-wise, or even telephone visits. Following up, behavioral health issues is really easy on the phone or in a video. And, we're trying to just sort of feel our way through what's going to be most effective for what type of visits. But some patients, really like them and some resist them. So we try to leave it up to the patient in terms of which way they want to communicate with us. We found that pretty helpful.
Great. We currently don't have any other questions. And there we go. I knew it would come right as I started to say that. The next question is, do you have set guidelines on items staff can manage that can reduce the amount of trickling down to the physicians? I feel that my front desk, LPN, and nurses don't feel comfortable closing items without the physician seeing it.
Yeah, that took us a lot of time to figure out. We have a lot of standing orders and protocols through this. The expanded rooming is pretty amazing, the things they do. Like if somebody is due for mammogram or colonoscopy or an immunization or something like that, they'll just go ahead and do it without even, asking me. It's all part of the standing orders. And that's part of trusting and empowering the staff, which takes quite a while to develop sometimes. It took us, for team culture, probably a good year to really get that established and each pod as they went onto team-based care. So yeah, that's really a good question. And I think that's where having staff involved with the development of these workflows is really helpful. And of course, having administrative buy-in for some of this stuff too.
Right. We have another question that was put in the chat. Can you give examples of ways you've seen facilities successfully empower the support staff to help the team-based care workflow?
One of the ways that I think you have to pay attention to is to talk to the providers. The physicians in particular sometimes have trouble giving up some of their, former responsibilities in these workflows. So encouraging them to support the staff as they try to do these new functions is really critical. There's some specific examples with documentation, because that's a big challenge for staff to learn how to do documentation. And it's interesting the difference in the physicians that are really supportive and nurturing the staff versus those that sometimes just dismiss their attempts. And we had a couple of people that would delete the whole note and just start over. And that just is really tough on the staff because for them, it's a big learning curve, and we really try to have the docs nurture these people as they're learning the new roles.
Thank you. The next question is, how do you manage well care visits on telehealth that require immunizations or a physical exam, etc.?
Yeah, that's a really good question. And there's a lot of debate about that out there too, about how much can you do in a physical exam on those types of visits. We personally just sort of resumed the visits with face-to-face visits, especially if they needed immunizations. If parents were reluctant for well check and immunizations weren't needed, we could put that off. But there's a lot of different innovative things going on around the country with this. Some are, I can't remember where it was, but they do a video visit for all of the other routine needs. And then they set aside a time, I think it's a half day, where parents bring their kids in just to get the heart and lungs listened to and any immunizations that were required. So this is all evolving so rapidly. And I think it's a good time to think about innovation and try to come up with some of these new ways to do things. But as far as us for the visits with shots, we'll still see them. But stay tuned. There's some interesting websites about, even for adults, what can you do on physical exam on a video visit. And as the implements with the iPhones develop, I am sure that's going to really evolve into the future, pretty substantially.
Yeah, absolutely. I do want to mention that Dr. Hopkins also discussed conducting physical exams through telehealth visits. So to this individual participant, I encourage you to go back to that video as well. It may be helpful.
Yeah.
Dr. Jerzak, I'm going to give participants another couple of seconds to see if any other questions come up.
Very bad.
Again, if you would like to say your question verbally, please feel free to use the raise your hand function. We're happy to unmute you so that you don't have to type it into the Q&A or chat box. Okay, well, I think that wraps up our Q&A for today. If there are any follow-up questions that you think of after this webinar, please feel free to email them to action.labs@ama-assn.org. We'd be happy to forward your questions along to Dr. Jerzak.
And Brittany, if I could mention one other thing.
Yeah.
Where the steps forward as we mentioned earlier, is really helpful for this. We're actually working on finalizing a new module on team-based care and telemedicine that I think is going to have a lot of specific examples, and I think it's going to be really helpful for people.
Yeah, and I would be happy to forward a direct link to the Steps Forward websites to all of our participants in the follow-up email, so you readily have that on hand. Thanks for mentioning that, Dr. Jerzak.
You're welcome.
Dr. Jerzak, thank you so much for your time and expertise today. To all of our attendees, thank you so much for joining us. We hope to see you again soon.
Okay, thank you.
Take care.
Okay, bye-bye.